This conference will now be recorded.
You're in charge, Peter.
We're good to go.
You can do
Don't
it.
get nervous. Don't get nervous, Peter. We got your back.
Yeah, I was gonna say, we've got a few moderators here, so I think we can make it happen.
Yeah. Okay, well, unless I'm mistaken, I don't see anybody new tonight.
Dr. Sheltier?
I think I've checked in with most. Ben Nathanson, do you have anything you want to bring up this evening?
Hey, Peter, your audio sounds great. Nothing
No.
tonight, thank you.
Okay, and I see Bryce has arrived too.
You and two.
Yeah, Peter, how come
You
you're
and two.
better today?
Okay. Bryce,
Wow.
Bryce, I suspect you have something you want to bring up tonight, correct?
Oh, go get the fire in the wastebasket going.
Anyway, I'm pretty sure you do. So.
The blue one?
Yeah.
It'll get caught in the wheels, be careful.
Yeah.
We don't want to hurt it.
No.
Just a reminder, once again, guys, if you're not speaking, please mute your microphone. Thank you.
Okay, we're gonna start off this evening. I don't see anybody brand new unless someone corrects me. But
Yeah, I
I'm
think
George.
we do have someone brand new.
Well, I'm not brand new, but
George, yeah,
it's been a
George, you've been on before though, right? A while ago, right?
yeah, maybe 2 or 3 years ago.
Okay, we'll give you some priority there. Okay.
No problem.
Hold on a second. Okay. We're going to start out with Jerry Deans. Some of you have met Jerry before on this call, and we're going to start off with Jerry because Jerry's in a challenging situation. So we give him a chance to kind of talk about his situation, and those of us that feel we might be in position to understand or help or whatever, we're here to support you and put our collective minds together and our hearts together, because Jerry's up against the wall a little bit here, which is a place that none of us want to be, but all of us are afraid we might be someday. So Jerry, let me give it to you, okay?
Okay. 22 years into this battle, I'm on my second round of chemotherapy. Along the way, I've had all of the standard treatments, radiation, I've had a radical prostatectomy, I've had immunotherapy, Provenge, I've had hormone treatment. I'm on my second round of chemo where I'm taking cabazitaxel and carboplatin right now, carboplatin. And had a whole lot of focal radiation treatment as well to go after spot treatments. So, I'm reaching a point where I'm exhausting all of the standard care alternatives, and and still need systemic treatment. So last week I had a PSA that bumped up to 100 after coming down to 60 some on chemo, on the dual chemo, cabazitaxel and carboplatin. Bumped up to 100. I'm hoping that that's just a measurement anomaly, and it'll continue to go down. I've been investigating the BITE trials primarily because my doctor Drake and my local oncologist here, Charles Drake, and my local oncologist have both highly recommended the BITE trials. And so I've been calling around. I've called Hopkins and Duke and University of Alabama, learning quite a bit about the BITE trials by Amgen. And there seem to be two that are going on. One is Amgen 160, which is if you are PSMA active, viable, I'm not sure what the right term is, but which I am. I tested positive on PSA a little over a year ago. And so I expected I would be PSMA positive still, unless something's happened to the cancer since then. But so one of them is based on being PSMA positive, and I don't know whether they rule you out because you're not PSMA positive or you don't have a measurable PSA or not. But that'll remain to be seen when I get further or deeper into these trials. If any of you have heard some of the videos, there's a lot of really high level excitement in the prostate cancer realm. Oliver Sartor and many others are really excited about these BITE trials. And so this to me seems to be the next best alternative to try to see if I can find one that's logistically feasible for me to get into it. And what I know about them is that they are, you get the treatment every 3 weeks. The first treatment, they watch you very closely. You're inpatient. But after that, you can get it in about a 30-minute period infusion and then just be under observation for a short period of time and leave the hospital. Come back 3 weeks later, get the next infusion. So both the Amgen 160 trial and the Amgen 509 trial, both of which are BITE trials, are working that way, treatment every 3 weeks. The 160 trials are combining some other drugs with the Amgen 160. And of course, the target is PSMA, but they're also pulling in, I think, immunotherapy drugs or combining immunotherapy drugs in some cases to give an extra boost to the treatment. So they're both in phase 1 trial. What I know is that Hopkins may be an alternative down the road, that Duke is going to be a possibility for the 509 trial. University of Alabama, Birmingham has the 160 trial. So those are what I'm looking at in terms of next steps. And I've been talking to Rick a lot about this, talking to my doctors.
Jerry, can I ask a question?
Absolutely.
Why only the Amgen trials?
Well,
I
think
there are about 7 different BITE trials for prostate cancer recruiting right now.
Okay.
And Amgen 509 and Amgen 160 are just 2 of them.
Okay,
So
tell me about the others.
Well, I can put a spreadsheet on the chat room, but they're, with a whole bunch of NCT numbers. But basically, for example, Regeneron has one that to me seems very promising.
Right. Yes, I'm aware of Regeneron, and that's an every 2 week infusion, and it's and Dr. Drake, I think, is actually a principal investigator on that. I guess I've been looking at something that I feel like I could get to that's close enough to my home, so it's logistically feasible for me to drive to it every 3 weeks, whereas New York City is going to require significant logistical twisting around. It's not that I can't do it, but yeah, I thought about the Regeneron trial as well.
I thought they had a site in Philadelphia.
You may be right. You may be right. And
But I think, you know, I agree that bites are extremely hot right now. And the results from the early results from all their trials show that there's mostly a dichotomy of a bunch of patients who respond and a bunch of patients that don't.
yeah,
Herb, is your sound turned down somewhat? I'm having a little trouble hearing you.
I don't know. How about, is this better? I moved the
Yes,
mic.
much better, much better. So
Okay.
before we get too far into this, so I am a pretty big novice in terms of the bite stuff. All I know is it's an immunotherapy type of treatment experiment. And so in layman's terms, because probably most of us are probably pretty naive on this one and not experts at all. In pretty layman's terms, it's being used or being tried for other cancers as well, like lymphoma and so forth.
Absolutely. So, for example, if you look at the Amgen website, they've got AMG, whatever, for many, many different cancers. And the whole point of a bite is that certain cancers, especially prostate cancer is amongst them, are considered to be, quote, in the oncology world, cold. That is to say, they don't have a lot of immune cells attacking the tumor. And the idea of a bite is to somehow bring the immune cell to the tumor. So it's like essentially, it's like a chain. And at one end, you're linked to the it tries to bring in the T cell, and at the other end, it's trying to bring in the tumor. So it's sort of linking the two to try to make the tumor accessible to the T cell. And so so there are two ends of the bite. One end of the bite is directed against the tumor. One end of the bite is directed against the T cell. So that's the summary of a bite. It's a very simple concept, right? You have the T cell wants to get to the tumor and the bite tries to get it there.
that's
So
my
Greg-
understanding as well. And the 509 trial uses a different target than PSMA.
Right. It's using STEAP1.
That's right. Right.
So Herb, I have a question that when I went on ADT, I came up with this recently diagnosed with lupus, which is anti-immune disease. And I just wonder if that's related.
I don't think it's related particularly to ADT.
Okay.
Right. I mean, Rusty, has it been confirmed that it's lupus?
Yeah, it has been confirmed, and it's mainly a female disease. And
Right.
I think because I went down, to zero testosterone or almost close to zero is when it came up. But the pain is real, and
Right.
my joints are a mess.
But,
Okay,
but
Rusty,
let
we'll
me
come
get back to Jerry.
I don't want to get
Let me
too
get back
far
to Jerry.
back to Jerry. I want to stick with Jerry for a little bit before we.
Yep, that's fine.
I promise you. Okay.
Well, I was here basically to share with what I knew about the BITE trials and seek any additional guidance. I am aware of the Regeneron trial. And, I think that when and if the chemotherapy stops ceasing to impact my cancer, then I'm going to be looking, for a systemic treatment, probably in a clinical trial.
So where are your metastases, Jerry?
My first metastasis was in 2006. It was in my lungs. Since then, I've had it at T11. I've had it in the left acetabulum. I've had it. I've got 2 spots on my ribs right now, relatively small spots. Okay, and I have a a radiation oncologist who has and will continue to treat spots to help keep this at bay. But I think it's pretty clear to me that a systemic treatment is going to be necessary along the way. So my two considerations are something that's logistically feasible to get to every 3 weeks, preferably by car. I'm in Richmond, Virginia. So Johns Hopkins would be possible. Duke University would be possible. Getting outside Charlottesville would be possible. And so beyond that, I'm still looking, hoping, and praying for additional alternatives.
So I've got a quick question here about what is the marker they use to determine if the BITE trial is working? How do you tell? Is it PSA? Is it
PSA decline? PSA decline is almost always what they're using.
Interesting. Okay. What about with other cancers where they're not measuring PSA? How do they know that?
They use other surrogate markers.
Okay. That answers that. Does anybody else have any questions about BITE and the applicable
But Jerry, what about have you tried lutetium?
I have not tried lutetium, so that's also a possibility. Is that FDA approved yet in America?
Well, you know, to be honest, I think the people doing it best are in Germany.
Yeah.
Germany and Australia, I believe, as well, right? Australia?
I mean, I know that NIH is planning on doing it at some point soon, but I don't know when.
Yeah, I had a close friend that actually went to Germany to get that treatment.
Yeah, I think
Jerry, I want to be aware that if you take lutetium, sorry, is someone else talking?
Go ahead, Len. Go ahead.
If you do go with lutetium, you may not be eligible for the AMG 160.
Yeah.
One of the exclusion criteria was any prior PSMA targeted therapy, which is what the lutetium is.
Okay.
And also just to touch on what Rusty was talking about before, any autoimmune disease like lupus could disqualify you or make you ineligible for just about any immunotherapy, because the last thing you want to do if you have an autoimmune disease is ramp up your immune system. Could make things worse.
Yes, thank you.
So a couple of things, guys. First of all, I apologize for being late, and we have really capable guys in my place, so that's perfect. But there's a couple of things I wanted to say, and I know if this was already mentioned by Herb, just tell me, but there were 7 trials that I found, 7 BITE trials. I know you've discussed the 2 different AnCan trials. I assume you've discussed the 2 different AnCan trials. There are 2 Xencor trials. There's a trial by Genmab, which I think is a solid tumor trial and not specifically prostate cancer, so it includes prostate cancer. And then there's a HER2. If somebody has a HER2 mutation, there's a trial, a bispecific trial using some sort of HER2 type of agent. Did you cover all of those?
No, we did not.
But Herb did bring up the fact that there are a number of trials, and it was considered that some of them were kind of out of the way, and there were other reasons why some of them might not work for Jerry. But we did talk around the edges of that stuff, Rick.
And the other and I see Bryce has a question. His mic's not working right now, and he has a question that maybe we can address in the chat box. But the other thing I wanted to raise is that it's very interesting to me that we've got 3 men on this call, all of whom in some way, shape or form have been impacted by lung metastases. Jerry, Bryce, and Frank. And is Ben Nathanson on today or not?
Yes, he is.
4. So we've got 4 men.
5.
5 men. Was that you, Lou? Yeah.
Yes.
We've got 5 men, all of whom, in some way, shape, or form, are having to address lung mets. And I mean, I don't know where to go with this, but I do think it's worth some discussion because lung mets are not common in prostate cancer.
Seems pretty common to me, based on this call.
Yeah. Listen, there's a few people on this call who would like to be wrestling with lung mets since 2006, Mr. Deans.
Perhaps Herb, could you take a few minutes to answer Bryce on the chat window? Because it's a little bit complex, his questions, way beyond my
I am typing.
Okay, great.
I'm typing right now.
Okay. So Jerry, we're gonna move on. I promised Rusty we'd come back to him because Rusty's missed out on the last meeting or two. He had to drop off before we could get to him, and he's got some pretty specific issues. So go ahead, Rusty.
I just want to say thank you so much. I've got to leave for another call tonight. I appreciate y'all giving me the time, and I will be following up to see which way we go with this, and I'll come back on to let you know.
Okay. And
Thank you so much.
I'm sure he'll keep us up to date too. Take care.
Yeah, good luck, Jerry. I learned a lot.
So my biggest issue is dealing with lupus now on top of cancer. And the lupus is tearing me apart with my joints, my muscles, everything. And just wondering if anyone else has had the same issue, because it appears it comes from ADT, because it's mainly a female issue, but you know, it just is extremely painful, and then adds to obviously the depression and, you know, just being tired.
Hey Rusty, are you taking any of those bone strengthening agents?
Well, I can't get in to see a rheumatologist until the 28th. So
No, I'm just wondering if you're taking like Dxed or any of those that may be causing joint pain.
I'm only taking over-the-counter Tylenol or Motrin.
Oh, I got you. So it's
Nothing.
Nothing possibly. Okay.
Rusty, are you seeing a specialist for lupus now too?
I'm trying to, but I can't get into the 28th.
And is that, you know, where are you going? Where's that going to be?
That'll be at the Elliott in Manchester, New Hampshire.
Huh.
You can't get into, nobody at Dana-Farber will talk to you on that?
What's that?
Nobody at Dana-Farber will talk to you on this one?
Well, I have a medical, a sports medicine specialist who recommended me, and they're getting involved right now to see if they can move it up.
So, Peter, Dana-Farber is a cancer center.
Okay.
Right. So it would be probably Mass General or somewhere like that. But the first question I have for Rusty is, Rusty, have you reached out to either of those 2 lupus advocates that I mentioned to you?
No, I have not. And
I mean, I think that's a really good place to start. You know that we truly believe in peer knowledge and peer support. And I think both these ladies that we talked about, because we're trying to start a lupus group here. We haven't gotten that far yet, but we've been playing with it for about 6 or 9 months. But both Helena Johnson and Turco, what's her first name? Danielle Turco are really good people, and I think they should be your first port of call because they've been through it. They know what you're doing. They're going to have the tips. They're going to be the right people to support you in this.
Well, I agree, and it's been difficult when you're dealing with all the different things. And yeah, I mean, here's my
Wow. I feel for you. So I want to make a comment here that has no medical backup to it, but personal experience. If you get offered the COVID-19 vaccine, be careful about the Moderna one, because I went through 2 days of muscle and joint pain right after my shot. So I just give you some personal experience with that. That, you know, I don't know about the other shots, but it raised hell with my muscle and joints.
I've had the Moderna shot. I got it a week ago and had absolutely nothing other than a sore arm for a day, and that was it.
Right. Well, I had both. I had the sore arm as well. And my daughter-in-law's taking the day off from work now because she's got the sore arm and muscle joints too, back and so forth. So it's just personal. I mean, some people go through it and have nothing. So I know that, but just saying, heads up.
Rusty, was that spot you just showed us, is that from the vaccine, from the COVID vaccine that you showed us on your arm?
Your mic is off, Rusty.
But no, the spot on my arm is a sign of having lupus, and unfortunately, I can't get in to see a rheumatologist till the 28th. But the pain is really bad, and nothing over the counter is working. So I called my regular doctor and see if they could, get me, in sooner. But I gotta say the whatever is happening to me, lupus or whatever, is a huge issue in my life right now.
Rusty, is the diagnosis for your lupus, is that still from the sports medicine doc, or has anybody else diagnosed you yet?
It's from the labs, from the sports medicine. I'm waiting to get in to see the rheumatologist.
Right. Well, why don't you check and make sure you've still got that email from me with Helena Johnson and Danielle Turco, and if not, send me a message and I'll get it to you again. But take a look right now and reach out to. They're both on the East Coast, one on Long Island and the other in North Carolina or South Carolina. So they're going to be of significant support to you right now.
Right. And Rusty, in terms of the prostate, that's all under control. You're off of drugs and everything. And PSA is okay and everything's in check there.
Yeah, I've got my PSA came back this week as under 0.004, which is the level they can check. Other concerns is having bleeding in my number 2s, and then of course the lupus pain. Along with that is depression and just being tired from everything.
Yeah.
Are you taking anything for the depression, Rusty?
I'm sorry, what?
Are you taking any meds for the depression?
Yes,
Good. Okay.
I'm taking Zoloft before I go to bed. It just
Okay.
low.
And does it make a difference?
Rusty, this is Jerry Pelfrey.
Hold on a minute, Jerry. Hold on a
Okay.
minute. Right in the middle.
All right.
Rusty, does it make a difference?
What does make a difference?
Does the Zoloft help you?
The Zoloft is definitely helps with the anxiety and road rage and
Okay.
change of moods. It's been great. I've been on for maybe 6 months now, but it's not.
It's not the bit. Here's what I would suggest. Who's prescribing the Zoloft? Is it your GP?
PCP.
Why don't you talk to the PCP about the dosage, given what is going on right now, and see if they recommend a change in dosage?
Could be.
Okay. And then you can titrate up to that. It's probably best to titrate up, but I definitely would suggest to you that you talk to the PCP about whether they think you're on the right dosage.
Yeah, I agree.
Yeah,
I've been on a lot of depression meds for about 40 years, and it really takes a while for them to get up to the right dose. So it's worth a try.
Yeah, I think I should talk to my PCP about increasing the dose of the Zoloft. It's been bad. This week's been very, very bad, and I mean it's because of my joints and everything hurting. So the Zoloft definitely helps, but I think I should increase the dose.
So this might be a little bit of a controversial suggestion, but I see a psychiatrist. I've done that for about 4 years, and that's who prescribes and works with me in terms of antidepressants or anti-anxiety stuff, because that's his field. And he knows it, and he knows the doses and so forth. And I've gone on and off a few times, but I still work with him. And it's a little bit controversial because a lot of guys think it's you can handle it on your own, and a general practitioner can deal with this. But there's nothing wrong with pursuing it with an expert. And I see his wife as a therapist. So just a suggestion, thought.
I got 2 counselors that I work with.
Okay, well, ask them if they know someone who, who's a psychiatrist who can prescribe meds to release the anxiety and the depression, because it can help.
I've never been to a psychiatrist, but I've been to a psychologist and counselors. But I probably need to.
Yeah, I never had either, but I bit the bullet, and I'm glad I did. Jerry Pelfrey, you had something you wanted to say.
Yeah, I was going to ask Rusty, with your pain, which I think is, causing you a hell of a lot of issues, can't you talk to your PCP and get a mild opiate like tramadol, which is a synthetic opiate? It's very non-habit forming.
Obviously, well, you guys might not know, but I have a addiction issue, and I don't want to go on an opioid.
Okay.
I have a question myself. This is John. Do we have to put up with this long delay before seeing a rheumatologist? There must be other alternatives. The lupus itself causes depression, even if it wasn't causing pain. And I'm really concerned about this length of time before seeing a specialist. Is that absolutely necessary? Isn't there someone else?
I contacted my sports medicine physician who used to be my PCP, and they're trying to move up the date, and I did that today.
Yeah, this is one of the downsides of the era we're living in with COVID. It's a, you know, the responsiveness of the medical community right now is pretty, well, I don't want to use the word poor because they're very responsive to the COVID, but trying to get appointments and trying to get procedures done and trying to get attention, no matter where you are, is very, very difficult. So I'm not making a case for the medical community, but I'm just sympathizing. I mean, it's you know, things we might not have put up with a year or two ago. We have to somehow endure sometimes these days, and it's a pain in the ass. I know.
This would have never happened 2 years ago. I mean, I should be able to get in and see a doctor within 2 weeks, and it's been, you know, now well over a month. But
Yeah,
I've got the scars to show for it, and I've got the pain, and I guess the depression that comes with it.
Len, do you have any experience with lupus and people who've been treated for it, or what's going on with that?
Well, I don't think there are many or any possibly effective treatments for lupus, unfortunately. But when Rusty was wondering if there might be a link between androgen deprivation therapy and lupus, I did a quick Google search for what it's worth. There was no consensus. Some articles were saying that there's a decreased risk of prostate cancer with lupus. Some said there was a decreased risk. So I'm afraid I can't help much there, Rusty.
Yeah, I did the research too, and I found, you know, articles that says that, you know, because of the loss of testosterone, that you have a higher increase, and then I've seen the other ones that say you should be more resilient to it. But whatever, I mean, I got it. So yeah, and it's mainly a female issue. So the only thing I can think of is it was based on, you know, my ADT and taking off the testosterone. So, but I skipped all the medical, you know, degree stuff. So,
Rusty, how long have you been on the antidepressant?
6 months.
Okay.
Yeah, 6 months, a year, I don't know, but it's minor, and it's a low dose of Zoloft.
I think it's David Muslin, Rusty. I think that Rick was on the right track when he asked you, or somebody asked, or no, it was Peter that asked if he'd seen a psychiatrist. You know the difference between a psychiatrist and a psychologist, right? And if you don't, I'm happy to explain.
No, I definitely do.
So you know, we got to get your head straight so you can deal with all these issues. When your head is when you're all depressed and your head's not thinking straight, it's hard to get anything done. If we get you to see a psychiatrist that can really get the right meds so we can get your head leveled off, then you can start challenging all the other issues that you're having. But I think we got to get you through that. I don't know who else agrees with that, but I'd love to see you go see a psychiatrist to get you the right meds.
I mean, I would agree, David, that if you're taking psychiatric drugs, they need to be prescribed by a psychiatrist. GPs,
yes,
other physicians don't know. They're just not trained to do it. I mean, Rusty, you're in a situation. Rusty, you're in a situation where you need multidisciplinary care, which to me seems like you're not getting.
No, I've been trying to get into palliative care, and I do have 2 social workers, but I think I need to raise it up and get better treatment.
But the psychiatrist can get you the right drugs so we can get your head straight, so you can get your head straight, and then we can help you deal with the other issues. And it's just like what I learned when I first came to this group that Jerry Deans introduced me to is we want to see a GU med-onc because they're the experts. It's the same thing with a psychiatrist. He's the expert who's going to help you get to the right meds to get your head level. So I hope you can connect those two dots, but I really gotta go see a psychiatrist, Rusty. It's going to help you big time. And then once you get that straight, then we'll help you start dealing with the other issues. But we got to get your head straight so you can beat the shit out of all these other things that you're going through, and we'll get you there.
Well, I appreciate the advice, and I'm going to take it, and I'm going to set up appointments, and I'm pretty functional, but also very depressed at this point.
Yeah. We can feel it. So we will keep in touch with us, call us personally, and make sure that we give you priority at our meetings, okay? You don't have to, we don't want to push it to the end, even if it's a quick update on how you're doing each week. I think it's important because we feel for you. We can hear it in your voice. We can tell that you're struggling with things, and we don't want to see that with each other. So let's keep on with it.
I appreciate the support, and it's a lot of pain and a lot of issues I have to deal with, and but that's why I'm here.
Right.
I'm not.
So,
This is
Rusty,
Frank.
let me ask.
This is Frank Fabish. I'm certainly not a doctor and not experienced with it, but I know from my past history, not from lupus, but HCQ, hydroxychloroquine has been used for lupus for many, many years, and successfully.
But that has to be prescribed from from a doctor, and and I can't get in and see him to the 28th.
Right.
Well, I've got another idea too there, Russ, and which is that call your oncologist, Roberts, was his name Roberts at Dana-Farber?
Yep.
And let him know that you may be wrestling with lupus. Now, that there is a connection between ADT and neuropathy. I don't know about lupus, but there definitely is a connection with neuropathy. And just tell him that you're having great difficulty getting in to see a rheumatologist. Can he recommend, does he work with a rheumatologist? Can he recommend a rheumatologist that you could get an appointment with quickly? In other words, use Dana-Farber to refer you over to Mass Gen or whoever they work with, and use that as a separate and different channel to your sports doctor.
Good idea. Yeah, I just keep banging on every door possible. Just keep knocking on the doors because one of them's going to open for you.
I would also add, if you happen to be a veteran, there's rheumatologists at the VA hospitals.
Okay, we're gonna move on. We're certainly not forgetting you, Rusty. We're all pulling there. We'll probably do some individual research on this one. We all know that the drugs we take and the treatments we have leave us very vulnerable for all kinds of things. Many of us have, because our immune system gets so compromised from stuff that, we've all been through different shades of hell. Maybe not this one, but we feel for you. Okay, Frank Fabish, you wanted to talk about something this evening.
Yes, I started my chemotherapy on the 7th, Thursday of last week. I took your recommendations from the previous call, went back to my oncologist, and I said, I'm not agreeing to start my chemotherapy unless you give me another CT scan to confirm the size of the lung nodules and whether on 3 months of treatment of Firmagon, if they've gone down in size. And if they've gone down in size, then I want to stay with that and see where it goes before going after the chemo. And he said he was open enough. He said he had no problems. Went for the CT scan right after Christmas, and the nodules, the 3 nodules on the lungs, hadn't changed in size. The good news was they hadn't changed in size or multiplied. The bad news was that they didn't decrease. So I went ahead and committed to start the chemo. I did it last Thursday, uneventful, but the last 3 days have really kicked my ass with the joint pain, muscle ache, spot pains, little bit of upset stomach. And but tonight has been a lot easier than the previous 3 days, but it certainly has had an impact on me. I'm hoping, I know from my discussion with Ken Anderson, that it'll start to get better starting tomorrow and the following days, because 3, 4, and 5 are supposed to be the worst days. But that's my update. I also got a blood draw before they started, and the blood draw showed my last PSA was 0.69, but in about 3 weeks it had gone up to 0.73, when my previous PSA before the 0.69 was 0.75. So it's still close, but I had expected it to go down, and it hasn't.
Are you on any kind of second line anti-androgen or ADT of any kind?
Yes, I'm still taking Firmagon, and in fact, he wants to continue my Firmagon through the chemo, and I'm taking the Firmagon every 28 days, the injection, and my chemo is every 21 days.
Right. Well, those of us that have gone through chemo, I don't know. I don't feel I got PSA results during the chemo. It didn't. I felt it was more the second line anti-androgens for me, which I took Lupron and Nubeco right through the chemo, and I think that was affecting my PSA decline more than anything else. But now that I'm just guessing here. I might be wrong on that, but a number of people who've done chemo who expect to see PSA changes right away don't really see them and get frustrated with that. Mm-hmm. So I don't know what anybody else feels about that, but it's.
Well, I just wanted to say, Peter, it's Ken. Hey, Frank, it's true. After the 3rd, 4th, 5th day, you'll start feeling better on chemo. But I would strongly encourage, go for walks during the day if you're able to, and if it's not, the weather's not too bad, because that just helps a whole bunch. Even on the 2nd and 3rd, all the days, just try to get out and do a little walk. Doesn't have to be long, maybe 2 miles or something, but you'll feel better quicker if you do that.
Okay.
And so you've only had 1 infusion so far?
Yeah, I had one of 6. So my next one is coming up on the 28th. And I also found out, I of course get all my other treatment through the VA. They were ready to get me a COVID vaccine shot, but my oncologist said to wait until a couple days before my next treatment, my chemo, before getting it because of my white blood cell count. And I did get Neulasta after the treatment. I got the device planted in my arm, and I did get a blast of that through the 27 hours after the treatment.
That's a pretty trippy tool, isn't it?
Yeah, it was amazing. to see that thing ticking away, and then all of a sudden, pop! It dispensed what it had.
Right.
Yeah, it was a little far out.
Yeah. You'll do. I mean, session 1 and session 2 they're not a walk in the park, but compared to, just kind of brace yourself, because infusion number 3, 4, 5, 6 are going to probably kick your butt pretty good. So I second what Ken just said. Try to get out, try to get some exercise. Really get in the habit of pushing yourself, because chemo is not a fun ordeal, and it's cumulative, and you'll feel pretty bad for the first week, particularly the first 10 days after number 3, 4, and 5, and 6.
Yeah, I was encouraged the first 2 days. I said, this is nothing. And then,
Right.
then the third day came along, and I felt like somebody was beating me with a stick in my shoulders, my knees, my back, and that caught me.
Anybody else have any thoughts on chemo for Frank, and suggestions?
Yeah, I do. Have you guys talked about the Claritin effect on the day before, the day of, and the day after Lunesta?
Yes, they told me, and I took that. They told me to start it the day before, and I brought your suggestion because they weren't talking about Neulasta to add it into my treatment, and I brought it up and said that through this group that they highly recommend the Neulasta with Claritin, and so they got that set up. And then, as you said, I'm on 5 days of Claritin, the day before, and then 4 days during the treatment, and then 3 days after. So I've been taking that.
Okay, good.
What about cannabis? For the guys who've been on chemo. I'm sorry. What about?
I haven't thought about that or considered it.
Yeah,
I haven't been on chemo, but when I went through radiation and I was beat up and dealing with colon issues, and the cannabis really helped a lot. It really just took the edge off. You might want to try some edibles or something like that. Start off with 5 milligrams, and it helped me a lot. But again, has any of the other guys that have been on chemo done cannabis?
I did a little bit of it toward the end of the cycles when I was experiencing nausea quite a bit, just to calm that down, and that I found it helpful for that.
Is that liquid over the counter?
Yeah, you have it in so many different forms now. I forgot, where do you live, Frank? What state?
I live in Ohio.
Yeah, is it legal dispensaries there, or only medical?
Yes, they legalized it about a year ago.
So I'd walk into a store. They seem to be very knowledgeable there. Walk into a store and tell them that you're on chemo, and what would they suggest? I'm sure there's other chemo patients that have been in there, and you want to take something that you eat rather than smoke it, I would think, and try it and see if that takes the edge off a little bit.
Luckily, I'm within driving distance to Massachusetts, and this is my relief just before I go to bed, and it helps me sleep, and it's completely legal. I can get a medical card for New Hampshire, but this is just a lot easier.
If you want, Frank, I'd be happy to talk to you about it offline. I can guide you through a little bit. I'm a little bit knowledgeable.
Okay. If you want to give me your number, I'll give you a call. I'd like to look at that.
Yep. Happy to. Coming your way.
Frank, it's a good idea. I've been using the combination of CBD and THC. They help each other. CBD is for pain and that. The THC gives you a little bit of a high. When it's combined with CBD, it negates the high and it accentuates the CBD. So the combination is really good. And I've been using it for 3 years. So it's really, I give my best to David, he knows, and I'm sure a lot of other people are using it too for cancer.
And what were the letters of the other one? The PCD and the other one?
T is in Tom, H is in Harold, C is in Carol.
Which means full marijuana.
When you
Go ahead.
When you call me, Frank, I'll fill you in with all those details.
Okay. Got it.
I'll get you educated quickly.
But I do feel it helps me at least sleep when all the anxiety and the issues with cancer and all that, it does help. And I just use a little vape pen that I buy in Massachusetts, but it does help.
Yeah, I've noticed my sleeping the last 3 nights with the joint pain has been very restless, and getting up every hour and a half, 2 hours. That's been going on for the last 3-4 days.
I got a smartwatch for Christmas, and it tracks my sleep, and it's terrible. And yeah, I've been diagnosed and tried to use a CPAP, and that didn't work. So that helps with a little bit more medication to help me sleep through the night.
Well, we feel for you, Frank. I mean, it dawned on me early on that, hey, I'm putting poison in my system every 3 weeks. There was no way around it. I mean, I knew it was going to be killing stuff, and not only the bad stuff, but the good stuff too. It's pretty freaky when you start thinking about it. So you're going to have some effects, but we're pulling for you. Many of us have been through it, and for me, 6 months later, I'm just hoping I get some mileage out of it. I'm hoping I don't have to go down that road again, but it seems to have done what it was supposed to do, and I'm happy for that. So we're pulling for you.
Thank you. Thanks, everybody.
Okay. There's somebody on the telephone. Do you want to identify yourself? Your mic is on. Who's on the phone?
Yeah, this is long lost Tony.
Tony. Happy New Year. Happy New Year. We'll get to you. Okay? It's good to hear your voice.
Yeah, it's good to hear you all's voices.
We'll have time to get to you tonight, I think, because there's not many people that have a lot to report. Carl, you're up next. Carl.
Okay. I have a really current update. I had an axonome scan. I had a PSMA scan, and both reports came back somewhat similarly. And I have to say that the axonome scan picked up a spot on my right femur in the bone that the PSMA scan, at least in the written report, they had not addressed, which I was kind of surprised because I figured the PSMA scan would be more detailed. But anyway, that's what's happened there. So my medical oncologist, with whom I'm having an in-person appointment tomorrow, I was communicating back and forth with him via email because I didn't want to wait until tomorrow to discuss what my possible next steps are, because the scans say that not only do I have a spot in the femur,
I also have something in his soft tissue area by the 7th rib. And so the medical oncologist had said, I said, well, is it going to be radiation? Is it going to be surgery or any combination thereof? He came back to say that his recommendation is radiation. So I found and it's kind of interesting. They said to me, do you know of a radiation oncologist? And I'm thinking to myself, well, aren't you guys supposed to tell me who you use as a radiation oncologist? But anyway, so I was able to find a radiation oncologist who's very highly regarded, one of the top doctors, radiation oncologist in the state of New Jersey, and 80% of his practice is for men with prostate cancer. His name is Edward Safin. And I had a telemedicine appointment with him a few hours ago. And he confirmed that he can address those spots with radiation. He also suggests that after the radiation is complete, I probably should stay on the olaparib for the near future. And that he also mentioned that as a follow-up, I may want to consider and discuss with the medical oncologist to go on to Xofigo, because I do have a number of sclerotic bone mets in my body. And I said, well, since they're sclerotic, should we still go with that? He said, absolutely. This is the time that Xofigo would be very effective by dealing with those sclerotic bone mets. So that's where I'm at so far. Tomorrow morning, I have my medical oncologist appointment. I will discuss that with him as far as doing the follow-up with the Xofigo. Also, as far as the radiation goes, I was told it would be 10 sessions. It would be done 2 weeks together, 5 days a week for 2 weeks, and it will be done that way. So that's my latest out there. Just throw it out.
Great. Well, we haven't talked about Xofigo in a long time here. I'm not sure if any of us have tried it. Has anybody gone to the Xofigo regimen?
Peter, can we first talk about the radiation?
Sure.
So, 10 treatments over 2 weeks sounds a little excessive to me, Carl. I think if it were me, I'd be finding somebody who does SBRT, because it's much more modern equipment, and going in and getting 1 or 2 sessions. I think it's a lot more efficient. It's a lot better. This guy's Afrin may have a good reputation in Jersey, but there are a couple of things that concern me. One is that he's still using IMRT and he's giving you as many as 10 sessions. It sounds like a lot. If it were me, I'd be concerned about that. The other thing I'd be concerned about is the Xofigo recommendation, which obviously you're going to speak about with your doc. But I don't think Xofigo's personally, I don't think it's a particularly good drug. It's not focused, it's not targeted enough. It also can eliminate you from certain trials, which I know has been a concern to you. I think at some point you're going to have to bite the bullet and think about doing some chemotherapy, and that might be the time right now, if he's concerned about what he thinks might be shown. I'm not quite sure what his rationale was. You can tell us again for the Xofigo. But if he thinks that there's something systemic going on, then maybe it's a good time to be thinking about that. But the first thing I do is see if I couldn't find a radiation oncologist that's using SBRT equipment and can address this much quicker.
Okay.
Anybody else have any comments about radiation?
Yeah, Peter.
Carl.
Okay.
Go ahead, Len.
I'd like to caution Carl about Xofigo also, because it's very well known to suppress the bone marrow. and you're already on olaparib, which has a substantial amount of bone marrow suppression. So you may wind up driving your platelets and your white counts down quite a bit. I would talk to your oncologist about that concern.
Herb, did you have something?
Well, I was just curious as to where your radiation oncologist is located.
Princeton.
In private practice?
He's part of a group. Princeton Radiation Oncology Group.
And did he say IMRT as Rick said, or did you know what method he's using?
No, he didn't specify.
Well, I think you got to get that down with him as to what technique he's using. And how many gray and where.
Yeah, I was a little surprised. The guy that I know, that the CyberKnife guy in Hartford, he does 5 treatments.
But that's for the prostate.
I thought it was for even Mets. No?
Usually less for Mets. Is there anybody on the call who has had spot radiation with SBRT?
I had similar frequency. I had 10 days of radiation to the spine.
But with IMRT, correct, George?
Yeah.
Right. But is there anybody who's had their Mets treated with SBRT? I mean, we have a lot of guys who have used SBRT for Mets. Is there anybody on the call today?
I think Jerry was on the call, but he's gone.
Yeah, he's gone. I mean, I know that Jerry, quite correct, Herb. I mean, Jerry got, I think I can look it up, but I think he got 3 treatments for his SBRT, with SBRT.
Yeah, it's pretty common. It's, I guess we euphemistically call it whack-a-mole, but it's pretty common for people to get short radiation doses to various spots just to keep going, and it's successful for a lot of people. I did a 10 treatment proton regimen for two small lymph nodes in my abdomen. I didn't even question. I mean, I was offered SBRT, but I chose to go to proton, and they brought it down to 10 treatments. And I think it was more the location of them and the closeness of them to sensitive organs that required lower dose radiation over a period of time.
Dennis McGuire has done SBRT. I'm looking who's on here, but Dennis I think he's having a problem with his microphone.
Yeah, I've
David
done it, Rick.
Muslin's raising his hand. David Muslin's raising his hand.
I've done it. When I had those 2 Mets zap this summer, it was about radiation with SBRT at Northwestern.
How many sessions, David?
3 in 1 week.
Yeah.
Monday, Wednesday, Friday.
Right.
No side effects, nothing.
Right.
Yeah, it's Dennis McGuire. I dialed in by phone. That's correct, Rick. I did SBRT to the prostate as well as to some pelvic lymph nodes. And I had 5 sessions over 2 weeks.
Right. I mean, the thing is, I mean, I think the IMRT probably works, but it's old technology. It's inconvenient. I don't think it's as good. And I am just concerned, especially as Len said, this guy's recommending Xofigo, but he knows you're on olaparib. I would have some concerns. I think I'd be going for a second opinion on for the RO, and I'd be seeking a second opinion from probably one of the docs in the city. That me personally.
Yeah, it's also kind of interesting that Safin, the radiation oncologist, knows Mark Stein very well, and so I hadn't spoken to Mark Stein in a while, but I did email him earlier this evening the information to see what he might think about treatment.
Yeah, hey Carl.
Yeah.
It's David. With everything that we learn here, why wouldn't you go get a second opinion no matter what? Sorry to be so direct.
Yes, and I've had multiple second opinions on everything else. You're right, and this is the first radiation oncologist that I've spoken to. Although, as I said, the reason being, and I will definitely take all of your thoughts under advisement seriously, but I guess his reputation is an excellent one, and another support group that I participate in, there are several participants who have used him and have raved about him. But like I said, second opinion is worthwhile.
But what have they
getting a lot of questions here.
What have they used him for?
I don't recall specifically, but he is a radiation oncologist. So
right. I mean, you see, I think the thing is this, that radiation oncology has moved dramatically in the last 3 or 4 years. And so we now see a prevalence of people, of these good ROs using SBRT rather than IMRT if they can. And some of these old guys are left with the old equipment and they don't want to talk to you about it because they don't have the right equipment. So now they'll go to CyberKnife or one of the other types of SBRT treatments, which are more effective treatments if it's available. But if they don't have that equipment available, they're not going to tell you.
Well, Rick, I just checked the site and they have SBRT at that group.
He may not use it.
Well, that's what I think Carl needs to ask him.
Right, right. If I were you, Carl, I'd be saying, I want to do SBRT. Can you do that for me?
Sure, I will listen to it.
But thank you, Herb, for checking. But I do think it's really important. But I think there's a bigger issue here, Carl. And the bigger issue is, and we've talked about it before, that you need systemic treatment. As Peter said before, this is whack-a-mole. And your disease with a BRCA mutation needs systemic treatment, because you can maybe nail it right now, but the likelihood that that's going to be long-term and the abscopal effect is going to have an impact for you is slimmer than most men who didn't have that mutation. And really if it were me, what I would be asking for is, what's my next systemic treatment going to be? And not, well, I found a spot, so I'll live with this, because 3 months from now, we're going to be talking to you when your PSA rises about what are we going to do next? And I think that's the question I would put out to the group, to everybody who's on here. Would you be doing spot radiation? Or would you be looking for another systemic treatment right now? One doesn't necessarily exclude the other, but the priority for me would be the systemic treatment. I had the same discussion with Jerry Deans this morning.
Yeah, I was speaking to someone who's here visiting, who's kind of in this boat, and but he had specific bone pain. He was suffering, and that's why he went to whack-a-mole radiation, just to hold off things for a while. But I agree with Rick. If the bone pain or the spots are not really causing any discomfort or concern or growing abnormally or something like that, you might want to focus on systemic treatment, because you can always go back. The other thing that occurred to me was that if you go with IMRT, it's not quite as focused, I don't believe, as SBRT radiation, and it could preclude further radiation down the road. If the field is too scattered and they fear that they're going to radiate the same place twice, that could cause problems down the road. So you want to be careful to, to make sure they're really pinpointing this stuff, if it indeed does need radiation at this time, and not just scattershot that could cause problems later on.
Well, also what I didn't mention before is that in addition, since this past Saturday, I've been having severe bone pain in my hip, in my right hip, and I'm having trouble walking. And that's why I went to an orthopedic doctor earlier today, and they did an x-ray, which was not conclusive, so he needs an MRI. But I'm not sure whether the decision to go with the IMRT might be relating to the hip pain, which they think there might be a hairline fracture at this point. Which, interesting enough, the Aximum scan and the PSMA scan, neither one of them have picked up. And I asked the orthopedic doctor about that. He said, well, in your medical situation, it could happen at any time subsequent to those scans, which was just 2 weeks ago.
Yeah, but neither an Aximum scan nor a PSMA scan is going to pick up a fracture. They are sensitive. They're both sensitive to prostate cancer. So those scans are going to tell you if you have prostate cancer in your hip, and the likelihood is, if they're both negative, that you don't. So you wouldn't expect either of those scans to report some sort of damage in your hip other than prostate cancer.
Okay.
Just to throw another little monkey wrench into the works, Carl, there is a proton therapy center run by that group in New Brunswick.
Yes, I know. Well, is that a possible option? Is that like SBRT, or that's just different?
Well, Peter can answer that question, right?
Well, my situation was different. I was going after lymph nodes in my abdomen, and one of them was pretty damn close to my heart, and I just did not want to go with SBRT. I wanted to get as specific as possible and exact as possible, so that's why I chose proton. But that was me. In another situation, I might have chosen SBRT.
Yeah, the other thing that I would want to drill down on, it just seems strange that the Aximum picked up this spot in your hip when the PSMA did not. Anybody here in the group want to comment on that? That seems to be an anomaly.
I mean, there is the anomaly that maybe that particular metastasis wasn't PSMA avid.
Yeah.
I think also in addition, the Aximum scan was a digital scan, and the PSMA scan was not. It was an older technology. It was a Siemens machine. So the Dr. Kranicki, who did the Aximum scan, thinks that it's possible because that the digital scan is just more detailed.
Possible. It could have been who was reading the scans too. Different people see different things, possibly. Okay. Well, Carl, we're gonna move on.
Okay, thank you.
So, Rich Jackson, do you have anything tonight? You came on a little bit later.
Nothing here, thank you.
Okay, Tony, you're in luck. We can hear from you tonight, even though we haven't heard from you in a while. Tell us how you're doing.
Well, I feel freaking miserable, just to put it bluntly. Basically, I'm on the Lupron and the Dxed. I've been on it since September of 2018. And, man, the side effects are kicking my you-know-what. But I understand you got to do what you got to do. Now, I've talked to a couple different people, and I don't know if this is a fact or not a fact, but if somebody tells you that you have to stay on Lupron the rest of your life, is that a fact or a myth? I mean, if it's working though, if it's, if it keeps working, if it keeps, I want to know, is that because my doctor did tell me, he did say, if and when the Lupron stops working, we will go to Zytiga, and then I want you to take, the Zytiga, and then and I guess also the Lupron. I mean that's what I'm thinking. So I don't know. I didn't think, when I first went on this Lupron, like over 2 years ago, because I haven't taken one break. I've been getting a shot every 3 months, and I was just under the assumption that, man, you ain't gonna take this the rest of your life. But I remember going into the center where I'm getting treatment, and even the oncology nurses, and they said, Tony, you're dealing with this type of cancer you have, advanced metastatic prostate cancer stage 4. This ain't nothing to mess around with. And they just said, they said, like I said, my oncologist's nurse said, Tony, it's just like I tried to tell you. She tried to, like, it's like having a jar, and you got your cancers inside that jar. And, as long as you take the Lupron and the Casedex, that's like keeping the lid on that jar and keeping that cancer suppressed. But when you take that lid off, hey, then it's Katie bar the door.
Well, Tony, all of us on this call have been in your place. You've only been on ADT for 3 or 4 months now. You're at the worst of it. The question of whether you'll be on for the rest of your life, the answer is it depends. Some of us go on and off. Some of us have been on it a long time. Some of us go on and have long breaks. But the short answer is it will change. You'll get used to it to some degree. And there are tricks and things you can do to tolerate it much, much better. So my first question is, do you exercise? Do you go out for walks? Do you make yourself push past the inertia that says, I would just want to lie down and die? I mean, do you make yourself do things?
I used to go to the gym, but I have been walking, and that's about it, because I'm going to tell you what, this severe fatigue is unbelievable, and this freaking brain fog, I'm getting about tired of this too. I mean, and I tell you what,
we've all been through the fatigue, and some of us are still dealing with it. And it's like a horse that doesn't want to cooperate. You got to whip your body out, get it out the door, and say, okay, I'm going to go for 2 miles today. I'm going to go for 3 miles today, and guarantee you'll start feeling better if you start making yourself, pushing your body a little bit. Anybody else have some comments about?
But what did you mean when you said I've only been on this AD&T for 3 or 4 months?
No, he said he's been on.
Anybody else want to comment about their experience with ADT for Tony?
Well, I guess I'm going to ask Tony a question first. Have you been measuring your PSA levels?
Yeah, every time. Here's what they do. Every time I get a shot of Lupron, they take my blood. They do my blood work, and they call me either the very next day, usually the very next day, and they tell me, because they'll give me a shot of Lupron and they'll give me a shot of Xgeva, which you guys all know that's for your bones and this and that. So the bottom line is this here is, and they take my PSA and they tell me what my PSA is, and it's been like extremely low this whole time. But what I thought I heard somebody say, they said, well, you've only been on this AD&T for 3 or 4 months. No, I've been on Lupron since September of 2018.
Right.
This is over 2 years. And here's what scares me. What scares me is I have read and I've heard doctors say that Lupron usually only works for 18 to 24 months. And it seems like I've heard that over and over again. And I'm past that 24-month period, if you get my drift here.
No, well, actually, you should be very happy because it's continuing to work. But what's your current PSA?
No, the PSA is real low. It's like 1 or 0.19, something like that.
Okay.
I mean, you know, it's low, but I mean, I just don't know. How long can you stay on? How long can you be on Lupron? Like 10 years?
Yes.
You know, I mean,
you can be on Lupron for 10 years, Tony. You can be on Lupron for 15 years. We don't know. It depends on your cancer and how quickly it responds. Some people, I mean, I'm looking to see if there's anybody here right now. There was a guy on the call at the beginning. He had to leave. He's been on Lupron since before 2006, on and off.
Wow.
All right. Now, Len, on and off, how long have you been on Lupron?
Well, after 6 years, I think I've spent half of my time on and half off. So, Tony, you might, why don't you talk to your doctor about taking a drug holiday and see what happens?
Well, that's going to go according to, like I said, when I get my shot, it'll be the 21st of this month of Lupron. That's when they'll also do the blood work and they'll tell me my PSA. So if it's staying low, you know, but what I'm saying is, what is the main difference between Zytiga and Lupron?
Okay, let's just right now. What are you on, Tony? You're on Lupron and you're not on Zytiga. I can't remember.
Casodex.
No, Casodex. Yeah.
You're just on Casodex and Lupron. Okay, so you got some options. First of all, you can try just remaining on the Casodex. That'll allow the testosterone to flow back into your body, but the Casodex will still protect you to some degree. Some guys do well on what they call high dose Casodex, 150 milligrams per day of Casodex. That's an option. Another option is to get off everything, like Len has done and Peter has done at times. There are guys on this call right now who have been on ADT drugs for years and years and who manage those ADT drugs. Dennis Correa, who is on a drug holiday right now, was on ADT and abiraterone for years and years, and then finally decided that he was going to take a drug holiday, right, Dennis? How long were you on ADT and abiraterone for?
About 5 years.
5 years.
Last couple of years, I was down to less than 0.1
right.
on a PSA, and so therefore, right now I'm on the drug holiday about 6 months, and I will get my blood work tomorrow, and we'll see what's going on.
Okay, so when these people tell me, like this oncology nurse at this cancer center, when these people tell me, well, Tony, you're gonna have to stay on this Lupron the rest of your life. That's not true.
You tell her to join our group and we'll talk to her. It depends. Some people, yes, if they can't get their cancer under control, they do. Other people, you might be on it for the rest of your life, but it doesn't mean you're going to be on it continuously for the rest of your life.
And that's where your intermittent therapy comes in, like going off for 6 months, correct?
Correct.
Yeah.
And what we're telling you are, you've got options. There are guys on this call, on this group, who are on intermittent therapy, have done different types of intermittent therapy. There are guys on the call right now who are just on a second-line drug like abiraterone or darolutamide, and they're not on the LHRH. There are lots of combinations in here. But one of the ways to get access to those combinations is to be sure you've got a doc who specializes in prostate cancer, because the docs who don't specialize in prostate cancer don't understand these options. And it might be for this oncology nurse, she's never seen anybody who got off the Lupron because she's in a community setting.
Well, this is that's a fact. She works at a cancer center in Wheeling, West Virginia, called the Schiffman Cancer Center, that had one of the most renowned cancer, and I can't believe he's gone. He retired after 30 years. He's famous. His name is Dr. Merrick. If anybody is around the Ohio, if anybody's on this call that's around the Ohio Valley, Dr. Merrick, very famous. And he
may be famous, but he may not be a prostate cancer doc.
No, he is a prostate. No, he does specialize in that. That's
okay. Let me tell you.
But he's tired.
I've been around this a long time. I've never heard of Dr. Merritt. So
he was there for 30 years.
Well, so there are many doctors who are in the same place for 30 years. It doesn't make them famous. It may make them a practitioner who's known, but they're not famous. And this guy, as far as I can see, well, I shouldn't say anything. Let's just say you need a specialized doc if you want to get more fancy with your treatment.
Yeah, this is a moot point anyway. If the guy's retired, we can't go around and around about what he would have done.
Exactly. Well, I wanted to go to that. I wanted to go to that Dr. Alpelman out of Pittsburgh, but he's not in my network.
Okay, then check on Cleveland Clinic. See if you can find someone there, or see if you can find someone in Columbus. I mean, there are people that probably are in your network that are experts that would possibly be good.
Well, let me ask you this: Are the MD Anderson clinics good when it comes to cancer clinics?
Depends where they are. Some are good, some are not good. For example, there's no good genitourinary medical oncologist in the MD Anderson clinic in Phoenix. Ask Ken Anderson. They won't refer him there. So it's not the clinic, it's the doctor.
Yeah. Well, I heard the best one is in Texas, but I was thinking about the one in Columbus.
We'll tell you what. I've got your email, Tony. I'll do a little bit of research and I'll look up and see if there's anybody in Columbus that might work for you. Okay, I'll communicate you with my email, but we're not going to do it. We don't have time to do it as a group here.
Okay, I got you, and I appreciate. Thank you very much for that. Thank you.
Okay. Well, I'll email you. Keep in touch with me on this one, okay?
Just as a reminder, I'm going to the James Cancer Hospital in Columbus.
Right.
Okay.
You've got a good doc, Frank?
Pardon me?
You have a good doc?
Yeah, very, very good.
Can you give us the name and?
Yes.
Tony?
His name is Amir Mortazavi.
Got that, Tony?
Yeah, Amir.
Mortazavi, Mortazav, like in Victor I.
You want to spell that one more time for me, please?
Amir, Amir Mortazavi, Mortazavi.
Got it.
Okay. See if you can contact him in Columbus. What's the facility is that, Frank?
It's the Ohio State James Cancer Hospital.
Okay. See if that's in your network, Tony, and whether you can make an appointment and just do an online call with him. You don't have to drive to Columbus right now. You could probably consult with him online as a second opinion.
Okay. Thank you very much. I appreciate it.
Okay. George Southey, we haven't heard from you in ages.
Yeah, I'm still here. It's great to see you guys. I've been wanting to come back to the group a little bit. Over the last couple of years, since I'm a physician and a lot of people know that I have metastatic prostate cancer, I've gotten at least 5 to 6 phone calls from guys that were newly diagnosed with prostate cancer, and and I always tell them that you gotta join a group, you gotta get some group support, because I mean, when you first get diagnosed with this disease, it's overwhelming, right? I mean, just coming in the group here, I mean, you got 25 guys, you got 25 opinions, you got you got all kinds of complicating factors, you got who do I go see, this and that, and so there's certain key things that I've done that have led to my success, I think. And one of them is not being afraid to call out a doctor and ask questions and say, you know what, I'm going to get another opinion. I mean, I got 4 opinions before I found a doctor that I wanted to see. Unfortunately, he retired, so I had to find another one. And then they retired, and I had to find another one. So I guess that's a good thing when they all retire and I'm still alive. But it's it's been quite a roller coaster. But in the end, I'm so grateful. I mean, I had metastatic disease when they found it. It was in all my bones, my ribs, my pelvis, my shoulder, my femur. I had a spinal cord compression. And so, 3 of the doctors basically told me the same thing. We're going to give you the Lupron. And when that stops working, we'll try something else. And I don't know if any of you guys know the look you get from doctors when you see them. It's kind of a look that that says, "I pity you. You're probably going to die soon." And I 3 of them did that, and I just said, no. So I found a doctor that was gonna take care of me and treat the cancer aggressively, because I think sometimes doctors reach a point where it's not their fault, because 10, 15 years ago things were different. If you got metastatic disease, they basically said, well, you're gonna be on Lupron the rest of your life, and that's it. And now they're finding that, well, maybe not being on it all the time is good. It's kind of like if you have a bad infection, right? You get put on antibiotics. Well, how long do you have to stay on the antibiotics, right? It varies, right, until the infection goes away. Because if you're on the testosterone too long, I mean the ADT too long, these cancer cells are smart. Some of them can develop without using testosterone. So those cells grow, and then they become resistant to the treatments. So it's like they say, it's complicated. It's individual. Right now, my PSA has been, because I saw my prostate, it started going up when I finished my treatment. And the question was, is the cancer back, or, is the prostate function coming back? And, it turns out that it went up to like 1 point something, and it stayed there. So it's been there for quite a while now. And, I still get it every 3 months, but, and a lot of the treatments that I'm hearing you guys talk about, they're all new from when I had my treatment in 2014. So, it's just, when I tell these guys to go find a support group, it's kind of like I feel like a hypocrite when I haven't gone in 2 years, because, I guess I needed a break too. I just didn't really want to think about it. but I know I still have it, and I have to keep an eye on it. And my depression's gotten better. I had really bad depression. It took me about 3 years to recover from the ADT. I mean, it really knocked me down. But the depression lifted. The fog's still there, kind of, and I'm still dealing with a lot of back pain. But I really think this group is great. I mean, I really recommend it to everybody. No matter because I think that you guys know more than most doctors know.
We welcome you back, George. It's great to hear you again.
Yeah, thanks.
Yeah. Hey Peter, don't forget Peter, I need a little time if we have it.
I know, you're next. Yeah.
Okay.
Can I just ask Dr. George, are you on ADT right now or not?
No, I was on it for about 2.5 years, and I was on enzalutamide, and I think he took me off the Firmagon first, and then we monitored the PSAs, and then eventually the enzalutamide. So, and then the Avodart, and I'm still on the metformin. I've been on the metformin for 6 years, and hasn't caused me any problems. And that's really it. I mean, I just.
So tell me, when you decided to go off enzalutamide and stuff, was your PSA at 1.5?
It was actually lower. But since back then, they didn't do anything when you had metastatic disease to the prostate. Now I think they take your prostate out if you have,
right. Well,
if you have metastatic
by the way,
disease.
Yeah, I'll just sneak it in that today was my first SBRT treatment in the face of metastatic disease. So, and that came from this group.
Great.
That's great.
Yeah, I think we'd all agree that this group is pretty amazing, and putting our heads together and our earths together comes up with some great options for it we never would have thought of by ourselves or with our doctor particularly.
Absolutely.
I just want to say for George, I mean, George, and how are your Mets? Are we still seeing Mets? Are we seeing no Mets? What are we seeing on the, as I recall, we didn't see too many.
No Mets.
No Mets. So
no Mets.
This is a good example, Tony, of how you can get off. And, this disease is so weird. It's different for every man. And here with Dr. George, he's now not on any type of hormone therapy. He still has a prostate. So that's maybe why he's producing a little bit of PSA, because his prostate has never been treated, and he's stable. And his head's finally in the right place, which took a lot. That was his biggest issue. It wasn't his ass. It was between his ears.
That's right.
Right.
The other question I had, of course, is that the latest stuff on metformin is not positive.
I don't care. It hasn't caused me any trouble. I mean, I don't have diabetes, but I do have. I'm overweight. I have hypertension. My cholesterol's not great. So they're actually even using it for that too now. But I'm afraid, what, when I was on my meds, I didn't miss a day. I mean, I was on a lot of different meds, and I trusted my doctor. And when you trust your doctor, it's really a big thing. And I did everything he told me, and I just did it, and it ended up in a positive way. But if there was any inkling that I was getting the wrong information, I would gladly say, you know what, I'm going to go see somebody else. Thanks.
Right.
You have to.
So it's not just a question of trusting your doctor; it's having a trustworthy doctor. And you went out of your way to find someone who's really on the ball. And as you say, the whole treatment game has changed in the last 6 years. And that doesn't mean you want somebody straight out of medical school, because they might not be a doctor either. You want someone who's really up on this stuff and who's an expert.
Is
So
it still Sweeney? Is it Sweeney who's running your care?
Yeah, he doesn't want to see me unless I have my PSA goes up, which I'm okay with, but I still would like to get a CAT scan and a bone scan like every year or two, because I was getting that for a while, and you know, just to keep an eye on things. And you know, I know the PSA is the thing that's going to go up first, but you know, I mean, I still get nervous, obviously, but and when he retires, I'll find another doctor.
okay. Okay, I want to.
How old are you, Dr. George? How old are you?
I'm 58. I was 51 when I got diagnosed.
Wow.
It's been 7 years.
Okay.
Yeah,
So
that's great.
I want to give David Muslin some time because he's been asking for some time before we finish up. Go ahead, David.
Tim, well, you know, it's a great segue because it's about trusting your doctor. And I've been seeing Dr. Maha Hussein out of Northwestern. And ever since I came down to Florida, we've been having telephone conversations with her. And the last 3 conversations, she's been confused and rushing and really had trouble connecting with her. So when I left Chicago in November, I do bone scans every 6 months, and bone scans and CT scans, and also did PSMA scans. But every 6 months I'm doing scans. With the last scan, phone discussion with her, she said, "Well, everything looks good. You're good. I'll talk to you in 6 months. There's something with the pulmonary with some nodules in your lungs, but I don't think it's anything. But if it's anything, I'll call you back." Calls back and said, "You know what? I spoke to the pulmonologist, and I think you need to get a scan in 3 months. No problem." So I scheduled it for February down here. This goes right up to Northwestern. All good. 2 weeks ago, I got a call from her. She's called me and, "Did you get the scan yet?" And I was confused. I said, "What are you talking about, get the scan yet?" And then it occurred to me, I'm supposed to be getting a scan next month. I said, "Why are you asking about this now?" Well, she says, "I got a note and there's some confusion and I think you need to get the scan, but let me check with the pulmonologist." I get a call back from a thoracic surgeon's nurse and said, "Yeah, we want you to get the scan right away." Well, with that news, and after listening to Frank for the last month, you know, I shit my pants pretty good. And very confusing calls. My life has been upside down. Long story short, I got the scan last week. I spoke to the thoracic surgeon this morning, and he says to me, "Well, how are you feeling?" He says, I feel fine. I'm running, I'm biking, I'm doing. He says, "Yeah, I see nothing on the scan. Whatever I see what you had in the November scan. This scan is totally clear. There's some very small, very, very small nodules, but he says it's nothing." So the question is, have I lost faith in Dr. Hussein? And you said, Dr. George, about, you really need to trust your doctor. I don't know if she just has a hard time communicating on the telephone, because when I'm with her, she's pretty good. And that's really what I want to throw out to the group. Should I look for another doc? Because I've lost, she scared me big time. And confusion is not good.
Anybody got a comment about this? How they're doing with their docs? I mean, I'm not making excuses for docs. They're all overworked, but I mean, they need to pull their own weight here and be there for us.
Well, I'd like to get Len's view, because Len switched docs. Len, what made you move from MSKCC to Mount Sinai?
Similar to what David's experience was, I didn't feel like my doc at MSK was on top of my case. I wasn't getting much more than about 10 minutes in the office, and I felt like I was being rushed out the door. So, he was a good, well-known GU medical oncologist, research oncologist as well. But that, you know, I didn't care what his reputation was. If you're not comfortable with the person you're dealing with, I recommend you do find someone else, David. Where are you in Florida now?
I'm in South Florida, Boca.
Boca?
Yep. And we'll go back up
Boca
to Chicago
Raton.
in June. Boca Raton, yep, on the East Coast.
All right, I have a good oncologist down here in Florida, but she's on the other coast, so it wouldn't be good for you.
But in any event, David needs somebody. He's in Chicago half the year and Florida the other half, kind of like you, Len. So
yeah.
The question is where.
Yeah.
Who else?
What about switching to Alicia Morgan's?
Well, I actually talked to Rick about that earlier today. Alicia works for Hussein.
Oh.
That could be difficult, because that's the first thing I said. I want to go to Alicia. I hear such wonderful things about her. And but the strange thing is, when I'm with her personally, Len, she's awesome. She'll spend as much time with me as I need, and I never really feel rushed. It's just been these phone calls. So maybe I just bring it up to her and talk to her about it, and maybe she'll just be honest with her.
Are you doing Zoom with her or just telephone? Because that might make a difference.
Just telephone.
I mean, I might ask someone. I know that Alicia Morgan's, I haven't talked to her over Zoom, but I know that she switched to that. And it might just be a more personal experience then.
Yeah. You know, she's a little bit older, Maha, and I don't know if she doesn't like to do the, you know, Zoom or GoToMeeting or whatever, but maybe that's what I need to do with them.
They've got a whole crew of people working with them that can figure it out. The other one, I don't know if you really go down to the south side. I really like Dr. Schmulowitz at UFC, but he was out of my network, which is why I went to Morgan's. Morgan's is a little more better bedside manner, but I thought Schmulowitz, he listened to he spent a ton of time with me, and when I went out of his network, he actually gave me a list of people to go see elsewhere, which I thought was really going out of his way. So just a thought.
Got it.
So David, I would say that we're going to have a session on managing your medical team. And I think if you're feeling like she's giving you short shrift, I actually would just say to her, I'm a little concerned here about our interaction. That when we're together, it seems great, but when we're on the phone, it just doesn't seem to work. So is there some way we can address it?
Yeah.
And I don't think she's going to get upset about that.
I don't think so either. It's a good suggestion, Herb. Thank you.
She probably never hears this from anybody else. Everybody else is just muddles around and thinks about it. But no, I mean, it's like anything else. We rarely confront each other with issues to resolve them. You know, we'll just resent and fume and all this stuff. But yeah, I think that's an excellent thing to do, is just talk to her about it. Not in an accusatory way, but in a way that you want so that you can resolve it.
I actually found that this group has solidified my relationship with my oncologist, because I've been able to take a lot of what I've learned from everybody and their treatments and their advice and take it back to him. And he has provided no resistance. He sits there, listens to it, and gives me an intelligent response, gives me why he's doing something. And it's helped develop our relationship further. And I think it's been very, very good for me and for my doc.
So it's 8 o'clock. Is there another meeting, Rick?
Well, I was just going to say, I have a comment that I want to make to David, but we've had a couple of people join us right now, and I'm not sure what meeting they're looking for. Michael Kazan, what meeting are you looking for? Your microphone is off.
Hi, I'm looking for RMC.
The RMC meeting is in the other room. It's in the Schmear room. You're in the Barniskis room, and it is starting right now.
Gotcha. Thank you.
Okay, can you use the other link? Can you find that?
Muted myself. I think I'll be able to. Thank you.
Okay. And Byron and Connie, what meeting were you looking for?
The advanced prostate cancer meeting.
You
where I know
found
we're late.
You found it, but we start the Tuesday meetings at 6 o'clock Eastern.
I know, we forgot about it till just now. Our fault.
Well,
that's probably true with you, Jimmy, as well.
Well, come back next Monday. Well, come back next Monday.
Oh, I can't hang on now?
Well, we're going to be closing up within about 10 minutes. So, and Jimmy, same thing. The Tuesday meetings start at.
I screwed up. I thought it was 8 o'clock. Much love. I'll be on time next Monday.
Okay.
I want to, Pat Martin, I know you just wanted to listen tonight. I hope you got a lot out of this. If you'd like, I know you don't want to speak, but if you'd like to put your email in the chat window, the chat window is a little bubble up on the upper right. It looks like a comic strip bubble for dialogue. If you want to put your email down in there, we will keep in touch with you and let you know when the next meetings are and so forth. But you're certainly welcome to participate at whatever level you want. I'm sure you got a lot out of this one.
And I saw Mike Krazan came back in again. I think he's left. He came back into the Barniskis room. He needs to be over with our RMC folks.
I see Jeff Coleman as well. I'm not sure who Jeff Coleman is.
Yeah, Jeff Coleman, which meeting are you looking for, sir? Turn on your mic. So
there you go. There you go. I'm a pretty smart guy, huh?
Yeah.
No, this is the one I was looking. This is active surveillance, right?
No.
Oh, for God's sake!
Surveillance is tomorrow at 8 o'clock. Tomorrow.
All right. Well, then I got an email saying it was tonight. I was just actually going back over to my email to check.
I don't think so. Look again, and I think.
All right, then. So much for being a smart guy, then, right?
Don't worry about it. You can.
I ain't. Believe me.
Listen, Jeff, you can stay in here, but these are all the advanced and recurrent guys, and we don't want to scare the you know what out of you.
Wait a second. Oh, you know what? Here's my problem. Yeah, okay. Today is Tuesday, ain't it? Yeah. There you go. There you go. Well, that sums it up right there. So you know what? I can't get back on any of these because I'm going to be too embarrassed. All right.
Come in tomorrow. You'll be.
All right. Very good. Hey, thanks for your time. Appreciate it. Thank you.
Pleasure. Now right. I got a question for David, which is really the $64,000 question, which is, since you've started treatment for the metastatic disease, Ma Hussein has been your doc. Are you happy with the way that she has handled your case from the beginning to now? Forget the fact that she's a little confused right now. We all are. It's like, you know, the world we live in right now does a big job on confusing us. But I think the big issue is, if you're happy with her performance since the beginning to now, you stick with her. If you're not so happy with the performance from beginning to now, then you got to start looking at whether you could get into Dr. Morgan's or not. We don't know, but there's good alternatives at UFC. But, you know, either Schmulowitz or Stadler. I mean, you've got good alternatives. And only you know whether you're happy and whether the confidence issue is just because she's a little confused right now. Can we hear you? Your phone's on.
No, that's better now.
Yeah.
Okay, sorry. The only thing that I've been unhappy with, where she's been very rigid, is when I learned from this group, and especially from Len, that I really wanted to go on darolutamide when I was so upside down on the, I think it's not the abiraterone, but what was the first drug I was on? I forgot now. Little brain fog.
Enzalutamide.
Xtandi.
Right.
Xtandi. She was very inflexible, would not talk about it, would not make any exceptions. And I hate to say it, but I got on the abiraterone and I'm fine. So at the end of the day, she's on it, and I think it's more of a communication issue on the telephone. And I think if I take Herb's suggestion and just be frank with her, I think it'll be okay. But to answer your question, I think I have been happy. Yes.
So I think it's a communication. Then I would say you got a communication issue. Don't make your life more complicated than it needs to be.
Thank you. I've been pretty good at that, but thank you for that, Rick. Pretty good. Thank you all.
Okay, guys, this has been a great meeting. I appreciate your patience with me. I mean, obviously, I'm not a newbie on moderating because I've been doing the low and intermediate for years. This is the first time I've done 2 in a row, yesterday and today. So I'm on a roll here. But thank you for your patience and understanding, and Rick for opening this up for several of us to cut our teeth and working with this. We're an amazing group of guys. And Pat, one more thing. I know you just wanted to listen, but if you're comfortable with this group, just looking at what you just wrote in the chat window, we meet again next Monday, 8 o'clock Eastern, next Monday. We meet every week with advanced cancer, and we'd love to hear your story. I mean, if you've been battling this disease for 6 years, and I'm guessing you're in Ohio someplace, we'd love to hear your story, that your successes and your failures and your concerns and your wishes. Anyway, so guys, thank you very much.
Great job,
Peter. I just want to say,
great job.
You did a fantastic job. God bless you. We had 30 odd guys on here, and I've got a lot to learn when I can, from you guys, obviously. I can bring in Peter next week. Herb's going to sit in the chair, and the week after that, Len's going to sit in the chair. And I am so grateful to you all for the job that you're doing, running these groups, and obviously to everybody for participating. Thank you so much.
Sure.
Thank you.
Thanks.
Okay.
Thanks, everybody.
Okay.
See you, everybody.
Bye.
Good night.
See you next week.
Take care.
Talk to you tomorrow, Frank.
Yeah,
Okay.
will do.
You going to close this meeting and reopen it?
Yeah, because we're recording, right? So yes.
Okay, I'll close it now, and then you can reopen.
They didn't have time.